All right, well, welcome everybody. We'll go ahead and get started just with the interest in time, since we only have about 30 minutes or a little bit less now. But we appreciate you joining the summit. Hopefully you're enjoying it so far. We are in Breakout Group 2, which is going to be dealing with MAT, medication-assisted treatment, with PWUD, people who use drugs. And so basically the goal of the breakout session is to come up with 2 to 3 goals that we would like to see around in this topic. So that would help maybe promote, enhance, or improve outcomes in that group. My name is Jay Mason. I'm the moderator for this group. I work at the West Virginia Clinical and Translational Science Institute in Morgantown, West Virginia, and run the Project Echo program there. So there's not too many people in the group, so I think what we can do is just let people kind of unmute. Also, if you have cameras and you can get on, that always helps as well as direct who's ready to talk and whatnot. Feel free to turn those on, but I think I'll just open it up for general comments around the topic of, what can we do? What are 3 recommendations we can give that would promote, enhance, or improve the outcomes for people who use drugs in the area of medication-assisted treatment? Anybody have any initial thoughts? Everybody's zoomed out from all the Zoom meetings so far with the summit. Understandable.
Hi, my name is Bethany Reynolds. I'm the perinatal hepatitis C coordinator in the Pennsylvania Department of Health. We are just starting our surveillance program, but I'm currently reviewing records for moms or pregnant people who have hepatitis C during pregnancy and outcomes for their infants. And the one thing I've noticed is that it seems like they have more of a chance of getting MAT while they are pregnant. And then after that, they sort of fall out of that care. And then we see outcomes progressively kind of spiral. So if there's some way to keep that coverage, and I don't know if it has anything to do with like the insurance coverage time for when you're pregnant and onward, but just keeping those folks linked to care somehow in that important time period.
Thank you, Bethany. Thanks, Dr. Cooper, for joining. We are just kind of getting started here, trying to get the ice broken a little bit. We're talking about MAT with people who use drugs. Bethany, great comment about pregnant women receiving the care and then kind of dropping off afterwards. And that is an interesting topic. I'm going to be taking some notes and doing some report out after our session, just so everybody knows. It'll just be a general kind of recommendations, because there is going to be a Q&A period after that where you guys will be more than welcome to chime in. So just keep that in mind. Any other thoughts? That's an interesting thought, though. How do we keep them in care after their pregnancy? Good thought. Andrew.
Hi, so I'm Andrew Hebert, health policy at Gilead Sciences. Bethany, quick question for you. Curious if you looked at payer mix of those women, just because, one thing that is catching on is extension of Medicaid benefits for pregnant women from, I think some states, usually it's like 8 to 12 weeks, but I know, for example, Tennessee, of all places, I think has or will be extending it to 1 year after delivery. And I think that's something advocates are pushing for in other states as a way to close that Medicaid coverage gap. So curious if, I know Pennsylvania has a pretty strong elimination planning group, if that's something they're exploring there, if Pennsylvania doesn't have that. But just curious if your data showed a pair mix of that and any disparities.
I don't have an exact percentage, but an overwhelming majority are Medicaid recipients. And we have heard of potential for expanding or extending that access to insurance, but I'm not sure where it's at currently in policy.
So just to add to that, and I don't know how much this factors in terms of what they're on during pregnancy in terms of the MAT. If they are on, so there's two forms of the buprenorphine. One is the Suboxone versus Subutex, and the Suboxone has the naloxone in it to deter any type of IV or intranasal injection or use and abuse of the medication. The ACOG, which is the obstetrical association, the National Association, a medical society for obstetrics, has not changed their guidelines at all around Suboxone versus buprenorphine. So pregnant women, according to them, pregnant women should be on buprenorphine monoproduct, which, and I've had a lot of problems with that in pregnant moms. In fact, it's not necessary. There's plenty of data that show it's safe in pregnancy now, but there's just not enough for ACOG to change their guidelines. And it'll probably be a long time before that changes. But in practice, most people actually do prescribe Suboxone now. But a lot of the pregnant women that I've treated have wanted the Subutex because the street value is a lot higher. They can sell it for about $60 a pill. Versus the Suboxone, which is about $30 at $20 to $30 a pill. And it's also very easily abused. You can inject that and it's just like it's an opioid basically. Whereas there's that, the blocker in the Suboxone. So, so what they will do is they'll put pregnant women on Subutex. And then after they deliver, they say, you're going to Suboxone. And the mom doesn't want the Suboxone. They want to stay on the Subutex. And then they may drop care because of that. That's one. I don't know if that's a factor, but I just want to throw that out from a medication standpoint. Because if a mom is really actively wants to get into recovery, then, as long as the payer situation is okay and, the transportation and all of that, then, she should be able to stay in care. But if she's really still kind of actively using or abusing the Subutex, that may be an issue moving forward with MAT.
Thank you. That's good information to keep an eye out for. We don't collect data specifically on which medications prescribed. It just asks if they have MAT during pregnancy, so I'll have to pay closer attention.
Yeah, it can be an interesting one.
Just to piggyback a little bit on the medication part of it, in West Virginia, we're seeing a rise in the number of doctors that are prescribing MAT. So the organizations are providing MAT, things like that. But we're not seeing is the same rise in the number of pharmacies that you can go and get your medication. Do we see that across other states? That's lagged behind. Or if we have a pharmacy that is willing to provide MAT, the medications, they'll cap it at some number that they say they're only comfortable with, or whatever it may be, guidelines. But is anybody else seeing that? Don't be shy.
I can jump in, but
Okay.
yeah, please, everybody, feel free. So I guess what my question in terms of West Virginia is, does Medicaid require prior authorization for starting somebody on buprenorphine?
Yes.
Okay.
And so that is definitely a hurdle for sure.
Yeah.
We just noticed that our numbers, there was a big push in West Virginia to, there weren't enough prescribers. Well, we got the prescribers going up, but the number of the pharmacies that are offering it, which are not many options in West Virginia, so that's, makes it even a bigger issue, is because we just don't have a lot of them. So how do you get them access to their medications?
Yeah, so that's a tough one. I will say we see that in Tennessee. I work both in Kentucky and Tennessee. I don't see that in Kentucky at all. Okay. And it's mainly, I think, because their laws are a little bit more progressive around prescribing. And, they don't have prior auths. It's kind of a pretty wide open situation, relatively to the other surrounding states potentially. But in Tennessee, there's a lot more restrictions. There's prior auths. If we change a dose, it has to be a prior auth. So I have patients that will go 3 days without their medications because they can't get the prior auth through for 3 days. So, I find that those, there's some correlation with the policies around that with Medicaid, linked to the linked to the pharmacy issue. And I've had conversations with pharmacists around, they have a prescribing limit. So just like we, as prescribers, the DEA has to know basically every time we make a prescription, and that gets potentially tracked. So, anytime, and the same thing with pharmacists. So if, I can only prescribe, like I have a limit of prescribing, right?
Sure.
To X number of people, right? So it's the same thing. They've done the same thing with pharmacies where you can dispense for X number of people. And so what a pharmacy will do is they will, say, I'm going to prescribe for X. And as long as that's fairly constant, it doesn't raise the flag to like the DEA.
Right.
But
yeah.
if this kind of keeps going up, or it's like goes up like that, then now they're potentially on the DER radar for now coming in for an audit. So that's really kind of, I think, the fear of the pharmacists. That's what's driving them to kind of keep their numbers down. Now, I don't know if, how much stigma plays in that, because I see a lot of that in the pharmacy world in Tennessee. So I think that's a major contributor. And I can tell you a whole bunch of stories around that. But I think that it's a lot of fear and kind of this regulatory fear that, both providers and pharmacists have, whether it's at the state level or the federal level, because it's really driven by law enforcement.
Any other comments? Thank you to Sherry and JXA21P for joining. Carrie, Jeffrey, I don't want to call anybody out. Share when you want to share, but love to get your opinions on anything. This topic, what we talked about. Any thoughts? Any recommendations? I guess one thing I've always asked when I get on these calls is, what's the new thing? Like one example they gave us was a mobile clinic. Has anybody done a mobile MAT clinic that goes around? Any innovative ideas that are kind of stirring around in anybody's heads? Listen, this doesn't bother me. This is like Echo. Echo is a virtual thing, so waiting for people to talk, not a big deal.
You need to send out virtual chocolate chip cookies.
Yeah, no, it's zoomed out. Yeah.
So I'll set one, and I don't know, I don't think this is out yet, but it's supposed to come out in the fall, was a new injectable for weekly buprenorphine, which, I am really excited about, because this can really change the landscape for MAT, especially in the mobile arena. Because, right now we write a prescription, generally we write a prescription, they go pick up the prescription from a pharmacy, and then they take it, and we do all these urine drug screens and try to make sure that they're taking it and they're taking it correctly and all that stuff. And so there's always issues of diversion or abuse of that prescribed medicine. But if we can start treating people with weekly injections, where they just come into the clinic every week, get the injection, that eliminates all of those issues. And so I think that, from a mobile standpoint, giving someone, you're mobile, and then you give them you send in a prescription, now you have to go pick it up at a pharmacy, right? I think the only issues around mobile is it's a controlled substance, right?
Sure.
So, with a mobile clinic, what are the pharmacy laws and legal issues around now doing an injectable in the field that is a controlled substance? So I think that's going to be a hurdle, but I think that potentially will change the landscape of MAT moving forward.
We are just starting to hear about that as well, Dr. Cooper, here in West Virginia, and same sentiments. Very excited about that with transportation issues in West Virginia. getting people access to that care, if you can give it to them once a week, that's a huge deal.
And we already have a once a month, but it's really hard, that's for very, very stable patients. So to get to
Right.
that point, is tough, but it's nice to know that what you're giving them is exactly what you're prescribing. And it's going to be in their system for a week. And so, yeah, I think it's a potential game changer. So.
Any other comments from the group? We got about 10 minutes left. Anybody else have any thoughts around MAT?
Is there any thoughts around MAT and hepatitis C treatment? Is anybody doing co-treatment of both, substance use disorder and hepatitis C out there?
Hey, this is Carrie Baldwin, a nurse practitioner with Prisma Health Internal Medicine Office, and we actually do MAT and hepatitis C together. Fortunately, here in South Carolina, we can prescribe. Of course, we have to have a collaborating physician since we're nurse practitioners, but we're lucky to have at our infectious disease, or at our clinic, we have infectious disease that comes in once a week. And so if we want to consult with them, it's very easy to do so. And the communication's great between everybody. So we've had a lot of success with that.
That's
Do you have any idea what your rate of success has been in terms of treating that population?
I would have to ask our research department, but I would say it's really high.
Great.
Yeah, the ones that actually, that take the medication, with a 98% cure rate, it's very high. So yeah, we have a lot of people that help us out and help us track patients. We've got spreadsheets, and we track to make sure that they're getting their labs and everything on time. We make sure that they're taking their medicine, not having any side effects. So there's just a whole team of people that are watching out from them from every angle.
That's great.
That's great. Yeah. Anybody else doing that? Doing the code? We do that in West Virginia a little bit, especially at the university side of things. We do a lot of that co-treatment. But is anybody else doing that?
Maybe another way to think about it too is, anybody tried to do it and ran into
It's true.
barriers or blockades that prevented it?
I have, one of the reasons that we do it in the MAT program here is because there were some GI providers that did not want to treat patients that were still using IV drugs.
Mhm.
And so that's where we kind of, we made it accessible to patients that are still using too.
Carrie, do you have what restrictions do you have for active use in South Carolina? Is there a 6-month waiting period or 3-month waiting period at all before you can treat?
No, there's not for us.
Okay,
Yeah, we
great.
treat, like when they come in for their initial appointment, we do a series of labs, the infectious disease labs. And as soon as it comes back positive, then we can immediately start the process of getting them treated once all the testing is completed.
That's great.
Yeah.
Yeah. That is great. Yep. No, I mean, the more you can catch them right at one visit, right, or when they're there, the more you can do with them, obviously, the better success, that you would have. And the nice thing about Hep C is that you can actually get rid of it, which is a positive thing for them, where they might not have that positivity right now in their life. So that's awesome. That's great news. Anything else before we wrap up here? I know David's going to put in the chat how to kind of get back to the main room for the kind of report out. There's going to be a Q&A session as well. There it is in the chat. Yep, thanks, David. So feel free to speak up there. It's going to be about all the different break rooms and different topics. And then I think it will be kind of closing it out here, wrapping it up for the day. But if there isn't anything else anybody would like to say, we'll kind of wrap up a couple of minutes early, so it gives you some time to, hop back and forth like we have
I
to.
want to bring up one more
Yeah.
thing for around MAT. Is anybody working with any or have any affiliation with like hospital or ED bridge clinics? Or starting those up? Or, has there been any discussions and barriers associated with that you guys have seen?
Dr. Cooper, in West Virginia, it's very hit and miss. The smaller, kind of critical access ERs and things like that, very hard to get them to kind of get on board. They're so overwhelmed. I think that just you're adding one more thing to them. That's usually what we hear from them. Bigger places at the university hospitals and things like that, a little bit easier. I think, we have, champions in those organizations that in the ERs that are really, pushing that and trying to dragging people along. But it's not been as successful or as, engaged as we would like. It's been tough.
Yep.
Yep.
Yeah, we're starting one in Kentucky that actually it's finally after 2 years, it's a go live later this month. So fingers crossed that, it goes okay. I'm sure there's going to be bumps, but yeah, it took a lot to get leadership, providers, and
Oh yeah.
all that stuff in place to just get the buy-in and then get it through whatever committees and all that stuff that needs to happen just to have a major change of protocol in the ED. But I'm hopeful that we can get some high-risk people into treatment that otherwise wouldn't have potentially gotten into treatment. So
that's great. Andrew, thank you for your comment in the chat. I don't know, can you just hop off and maybe state that in case people can't see the chat, what you said?
Oh, yeah, sure. And speaking with SUT providers in other states, South Carolina is unique in that with their quote unquote sobriety requirement, they do allow patients actively enrolled in substance use treatment to get approved for hepatitis treatment. But I know in other states that have gone like a soft sobriety restriction, several other states have this too, but I think there's an assumption among some SUT providers that any patient who's not totally sober, who hasn't completed treatment, isn't either not a good candidate, or they just assume that Medicaid won't approve the treatment, because in the past that certainly was the case. So as states start to loosen these, it is a good way for those patients to get treatment, and Medicaid will approve it. So just something to keep an eye out for.
A lot of appeal letters. That's what we do. A lot of appeal letters to get waive that, hopefully get past that requirement here as well. Yeah.
So I don't know if you've seen the peaks of this, but there's a pretty large, kind of a third peak for hepatitis C in the young population. So primarily like the, like 6-year-old to 12-year-old range. And that's a lot from maternal child transmission. So it's, I think one of the pieces, and this isn't, a lot of this stems from substance use, where, women who do have hepatitis C, they may have gotten tested in their prenatal visit, they may not have, but those kids get lost to follow up very easily. Sure. And I'm sure the perinatal program here can chime in, but we can start treating those kids earlier. But unfortunately, a lot of them are very hard to locate, in their, childhood time. So, I think in terms of just testing, when I talk to OBs and departments around making sure that they have appropriate continuity after delivery with pediatrics, and making sure if there's, that most states have registries now that hopefully can find somebody, but again, people are very hard to find. So, I think that's another new wave for Hep C that we have to be really concerned about and get treated are the kids.
Thank you guys. It's 3 o'clock. We're gonna kind of have to switch gears here, but I appreciate everybody coming and voicing their opinion, and we'll see you back in the main session for the report out period. Thanks, everybody.